It's time for the 3-question warm for Renal 5. Let's get going. What bacteria is an obligate aerobe and a gram-positive spore-forming rod? There was a typo in the study guide. It was supposed to be obligate anaerobe, which would be Clostridium species. But since there's no correct answer for the question that was printed, you can just ignore this one. Next question. Why are aminoglycosides ineffective against gram-positive anaerobes? Well, aminoglycosides are ineffective against gram-positive anaerobes because they are antibiotics that require oxygen to enter into the bacterial cell. So remember that you can use the O2 and amino O2 glycosides to help you remember this. Aminoglycosides are commonly given for gram-negative infections. Now, what do we use for anaerobes? You want to think about something like metronidazole and clindamycin. Next question, what part of the basal ganglia, if lesioned, causes hypokinesia? So this is the substantia nigra pars compacta, which can be affected in Parkinson's disease. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about some electrolyte disorders because the kidneys are integral to maintaining balance of things like sodium and potassium and calcium in the serum and in the interstitial fluid. Now, one of the ways that the kidney maintains homeostasis of these electrolytes is through hormones. We don't often think about it, but the kidney is actually a very important endocrine gland. For example, the JG cells, the juxtaglomerular cells in the kidney, make renin when they're stimulated by one of three things: epinephrine acting on the beta-1 receptors, perceived low blood pressure in the afferent arterioles, or low sodium in the distal tubule as sensed by the macula densa. So again, that ties directly into sodium balance. And then in terms of maintaining calcium balance, the kidneys help to convert vitamin D to its active form. So the skin makes vitamin D with the help of UV light. And then the liver adds a hydroxyl group, so you have 25-hydroxy vitamin D. And then the kidneys have an enzyme called 1-alpha hydroxylase that adds a second hydroxyl group to make 1,25-hydroxy vitamin D. And that's the active form. And that's facilitated by PTH. So if there's a lot of PTH, a parathyroid hormone, around, you'd have more vitamin D around. And the main thing that vitamin D does is increase the intestinal absorption of both calcium and phosphate. When we get to hematology, we'll talk about how the kidneys make a hormone called erythropoietin, which stimulates the bone marrow to make more red blood cells. So with kidney disease and kidney failure, erythropoietin levels are low, and these patients will be commonly very anemic. So we often give shots of erythropoietin to kidney failure patients. And then the kidneys also make prostaglandins, which dilate those afferent arterioles and increase GFR and increase renal plasma flow. This is actually a paracrine function because it's happening locally rather than sending this hormone off to some distant site in the body. And we talked about how NSAIDs can reduce prostaglandin production and therefore reduce GFR. Now, those are the hormones that are produced by the kidney. What about hormones that affect the kidney? Well, I just mentioned how PTH stimulates the kidney to activate vitamin D. PTH also stimulates the kidneys to increase reabsorption of calcium and to decrease reabsorption of phosphate so that serum phosphates go down. Remember, we said PTH is phosphate trashing hormone. We've also talked about the renin-angiotensin-aldosterone system several times already, so that's how hormones affect the kidney. Another hormone we've mentioned before is atrial natriuretic peptide, which is released by the atria of the heart in response to increased atrial volume and increased atrial pressure. So if the heart perceives that the atrial pressure is too high, it can send a hormone signal to the glomerulus to constrict the efferent arterioles and dilate the afferent arterioles. And that's going to increase GFR, and that's going to lead to diuresis. So ANP does the opposite of aldosterone. Instead of retaining fluid and expanding the intravascular volume and raising the blood pressure, ANP causes diuresis and helps to reduce the blood pressure a little bit when the atria become overfull. The kidneys also respond to vasopressin, which is also called antidiuretic hormone, or ADH. And we've seen how ADH permits the collecting tubules to reabsorb water and therefore concentrate the urine. Remember, antidiuretic hormone causes anti-diuresis, which means you're retaining water and you're concentrating the urine. Next, let's talk about two disorders that are both related to ADH. First, we'll talk about the syndrome of inappropriate ADH, or SI-ADH, where you have too much ADH. Then later we'll talk about a deficiency of ADH, which is diabetes insipidus. So SI-ADH means you have too much ADH. So you're reabsorbing too much free water and you're excessively concentrating the urine. So these patients have very concentrated urine and very dilute serum. They have low serum osmolality and low serum sodium. That's why we're talking about it here. SIADH is a very common cause of low sodium. So what causes SIADH? Where's all this ADH coming from? Well, ectopic ADH production from a small cell lung cancer can do it. That's a paraneoplastic syndrome. Really, any pulmonary pathology can cause SIADH, COPD, pneumonia, anything in the lung. And also, anything in the head can cause SIADH. So head trauma, stroke, CNS infections, anything going on in the head. Sometimes drugs can cause it, especially the immunosuppressant cyclophosphamide. But you're going to see lots of people with low sodium and SIADH. You're not going to see lots of people on cyclophosphamide. And then plenty of times you won't identify a specific cause. It's just idiopathic SIADH. One other thing that you should know is that if you correct hyponatremia too quickly, you might cause lysis of the myelin in the pons, and we call this central pontine myelinolysis. It's one of the causes of the locked-in syndrome, where the patient's conscious, but they can't move anything, they can't communicate, so it's a pretty devastating complication. Then the opposite of too much ADH would be too little ADH, which is the problem in diabetes insipidus, or DI. Now, what does DI look like clinically? Well, ADH helps you reabsorb water in the collecting tubule so that you can concentrate the urine and produce less urine. So without ADH, you can't concentrate your urine. So you have increased urine volume, and urine is very dilute. So this is going to cause highly concentrated serum as a consequence. So the serum osmolarity is high, but the urine-specific gravity is low. Now, there are two flavors of DI. There's central DI, where the pituitary isn't producing ADH normally. So if the pituitary isn't making any ADH at all, we call that complete central DI. More commonly, the pituitary makes just a little bit of ADH, but just not enough. So we call that partial central DI. So central DI is one big category of DI. The other category is nephrogenic DI, where the kidneys have become unresponsive to ADH. So the pituitary is making ADH normally, but the kidneys can't respond to it. So what would make the kidneys stop responding to ADH? Well, lithium is one thing. We looked at this slide earlier, and I warned you that it's going to come back to haunt us. This is the mechanism of how lithium causes diabetes insipidus, and it's worth knowing this mechanism. Remember, ADH causes the principal cell in the collecting tubule to insert these aquaporin water channels into the luminal side of the cell so that water will be reabsorbed. But lithium interferes with that process. So lithium is one drug that can cause nephrogenic DI. Another drug is dimeclocycline, which is a cousin of tetracycline. Dimeclocycline also interferes with the action of ADH, so sometimes we use it off-label to treat chronic SIADH because you're blocking the action of ADH. I don't know if I've ever seen dimeclocycline used as an antibiotic, but I have seen it used for SIADH. But because it prevents the kidneys from responding to ADH, it can cause nephrogenic DI. Hypercalcemia can potentially cause some nephrogenic DI as well. And there's also a hereditary form where you simply have a mutation in the gene for the ADH receptor. Now, I have heard that students are being asked to interpret test results and recognize what type of DI a patient has based on their labs. So, say you have a patient who presents with excessive thirst and polyuria. Well, the first thing you're going to think about is diabetes mellitus, which you can easily rule out by checking the urine for glucose and checking the serum glucose. But say those tests are normal. The next thing you would test is the urine and serum osmolarity. And what would you expect those labs to show in a patient with diabetes insipidus? Well, they're losing free water in the urine. So urine osmolarity is very low and serum osmolarity is high. Then the next test you do to confirm the diagnosis is called a water deprivation test. This is where you restrict the patient from drinking water and then recheck the urine osmolality. Now, a healthy patient will get slightly dehydrated when you water restrict them. They're going to start secreting some ADH and start concentrating the urine. So if the urine osmolality rises, that's a normal response to the water deprivation test. But in a patient with diabetes insipidus, they can't concentrate the urine. So urine osmolality is going to stay low. So that tells you that the patient definitely has diabetes insipidus. Then how can you tell if it's nephrogenic or central diabetes insipidus? Well, the next test you need to do is called a desmopressin challenge, where you're going to give the patient an ADH analog called desmopressin. And that's going to help you figure out if the patient has central DI or nephrogenic DI. If you give desmopressin to a patient with central DI, the urine osmolality is finally going to rise because you've corrected the ADH deficiency. You've given ADH. But if you give desmopressin to a patient with nephrogenic DI, that patient already has plenty of ADH circulating, but the kidneys can't respond to it, right? So if you give desmopressin to a patient with nephrogenic DI, the urine osmolality won't change. So how do we treat diabetes insipidus? Again, if it's central diabetes insipidus, then the treatment's just to give intranasal desmopressin. You're going to replace the hormone that's deficient. But for nephrogenic diabetes insipidus, the treatment's a little trickier. First-line treatment is hydrochlorothiazide, or HCTZ. And that doesn't automatically make sense. They've got diabetes insipidus, so they're peeing too much. Now you're giving them a diuretic to make them pee more. Well, the deal is that the hydrochlorothiazide causes the patient to become a little bit dehydrated. And that means that back in the proximal tubule, remember the workhorse, the proximal tubule, the kidney is going to reabsorb more water, so that by the time the urine gets to the collecting tubule, it's already a little more concentrated. Remember, the proximal tubule and the loop of Henle tend to concentrate the urine. The distal tubule dilutes it. So then the collecting tubule is supposed to concentrate the urine again. So HCTZ is basically preventing the distal tubule from diluting the urine. So HCTZ is the first-line treatment for nephrogenic diabetes insipidus. Second-line treatment would be indomethacin, which can also be used in addition to HCTZ. So you can give both. Indomethacin is going to inhibit prostaglandin synthesis, and that's going to reduce renal blood flow, and that'll decrease urine output somewhat. And if you're treating lithium-induced nephrogenic diabetes insipidus, the potassium-sparing diuretic amiloride is also particularly helpful. Amiloride blocks the sodium channels that lithium uses to enter the principal cell. So sometimes when you have a bipolar patient who really needs lithium, but he's getting diabetes insipidus from it, you can add some amiloride and that'll allow the patient to stay on lithium. I mentioned that SIADH is a common cause of low serum sodium, or hyponatremia. So let's briefly talk about some of the important signs and symptoms associated with electrolyte disorders. This is very, very testable. So they might give you a clinical scenario and show you an EKG and expect you to recognize if there's hyperkalemia, for example. So let's look at some high-yield electrolyte disorders. First of all, hyponatremia, or low sodium, can cause confusion and altered mental status, especially in the elderly. It can also lead to seizures, it can lead to stupor and coma. Now, that's pretty nonspecific, but just be aware that when the electrolytes get out of whack, it messes with the resting potential of neurons, and that causes CNS problems. Another disorder that classically will cause some confusion is hypercalcemia. Now, in endocrine, we have a whole video on calcium metabolism. And Dr. Cox is going to discuss all the clinical manifestations of hypercalcemia, which include stones, bones, abdominal groans, and psychiatric overtones. So those psychiatric overtones can include pretty serious confusion and delirium. These patients can get crazy weird. Then with low calcium, or hypocalcemia, you need to remember tetany, which we test for with Trousseau sign. Remember T for Trousseau and T for tighten the cuff, tighten the blood pressure cuff on the arm, and causes carpopedal spasm. And you can also test for Schwastek sign, so CH for cheek and CH for Schwastek. You're tapping on the cheek, tapping on the facial nerve, and getting facial nerve spasm. And then hypomagnesemia, or low magnesium, will also cause tetany. But then hypermagnesemia, or high magnesium, will depress the reflexes. So if you give IV magnesium to a pregnant mom who's in preterm labor, you're giving it to try to suppress muscle contractions and stop the labor. But if you give too much, you'll cause hyporeflexia. So if we're giving a magnesium drip, we're going to do serial neuro exams, and if the DTRs go from 2+ down to 1+, you know you need to stop the magnesium for a little while. You're getting a little too much magnesium. Then going back to hypomagnesemia, or low magnesium, that can also cause EKG abnormalities and arrhythmias. So low magnesium causes a wide QRS complex and could cause torsade de pointe, which is a form of V-tach, where the V-tach has variable amplitude. So it gets bigger and then it gets smaller, bigger and smaller. It's pretty easy to recognize. And speaking of V-tach, I want you to remember that low magnesium and low potassium tend to go together. So hypokalemia can prolong the QT interval and lead to V-tach and torsades, just like low magnesium can. And actually, hyperkalemia can also lead to V-tach. Potassium's kind of like Goldilocks. It's got to be just right, or you can get into trouble quick, whether it's too low or too high. But the classic EKG findings I want you to remember with hyper and hypokalemia are that the T waves tend to mirror the potassium levels. So if the potassium's high, T waves are going to be high. They're going to be tall and peaked. We say the T waves look sharp, like you wouldn't want to sit on them. They're sharp and pointy. But if the potassium is low, then the T waves are somewhat flattened. And if the potassium is really, really low, you might see a prominent U wave, which is a wave that comes after the T wave. Now, while we're talking about potassium, let's look at number 4 in your study guide and talk about potassium shifts. Like I said, serum potassium needs to be just right. So serum is relatively low in potassium, but the intracellular fluid is relatively high in potassium. So what kinds of things shift potassium outside of the cells, and that's going to cause hyperkalemia and potentially affect the heart? Well, low insulin can do it. So diabetic patients might be more prone to have hyperkalemia, especially if they're in DKA because they have low insulin. Beta blockers can shift potassium out of cells. Acidosis can also do it. Remember, with acidosis, your cells are trying to correct the acidosis by moving all those excess hydrogen ions out of the blood. They're trying to raise the pH and get rid of that hydrogen ion in the blood. So the mechanism they use to accomplish this is to exchange hydrogen ions for potassium ions. And that results in pumping too much potassium out of the cells into the blood. So acidosis can lead to hyperkalemia. Then digoxin can shift potassium out of cells. And then cellular lysis can do it as well. If your cells die and they rupture, they're going to leak all that potassium into the interstitium and into the blood. Then what kinds of things shift potassium into the cells? Well, it's just the opposite. Insulin, beta agonists, alkalosis, and cell creation or cell proliferation, like with cancer. Now, why is this clinically relevant? Well, I mentioned that exam scenario where you have to recognize hyperkalemia. So again, what does hyperkalemia look like on EKG? The T waves match the potassium level. So high potassium makes the T waves tall and peaked, right? That's what you said, right? Speak up next time. So if you see tall, peaked T waves, you're going to think about hyperkalemia. Then you need to treat it before the patient goes into VTAC and cardiac arrest, because that's a bad thing. So you need to figure out a way to shift potassium back into the cells as quickly as possible. So one thing you could do to help correct this hyperkalemia acutely is to give the patient a beta agonist like albuterol. Give them some nebulized albuterol because that's going to help the body shift potassium into the cells. Alkalosis could help too, so you can give IV bicarb as well. You can also give some insulin, especially IV insulin. The only caveat here is that the insulin is going to also rapidly lower their blood sugar. So we're going to give some IV dextrose and then the insulin. So you give the dextrose first and then you give the insulin to make sure the patient's glucose doesn't bottom out. So 3 emergency treatments for hyperkalemia would be a beta agonist like albuterol, IV bicarb, and IV insulin plus dextrose or D50. All right, that brings us to the end of session quiz. So have a look at those questions and then I'll go over the answers with you. First question, which electrolyte disturbance fits each of the following presentations? So the first one says, correcting too rapidly may result in central pontine myelinolysis. That's hyponatremia or low sodium. Peaked T waves would be hyperkalemia or high potassium. Tetany would be hypocalcemia or low calcium. Arrhythmias could be high potassium, could be low potassium, or could be low magnesium. Decreased deep tendon reflexes would be high magnesium. And flattened T waves with U waves on EKG would be low potassium. Next, what are the diagnostic features of diabetes insipidus? Well, the patient's going to have polyuria, and the urine is going to be dilute, so you have low specific gravity and low urine osmolality. Then on water deprivation test, if the urine osmolarity does not rise with water deprivation, that's diagnostic for diabetes insipidus. Then you're going to distinguish between central and nephrogenic DI by giving desmopressin. So if you give desmopressin and the urine osmolarity rises, this points towards central DI. But if the urine osmolarity does not rise, this points toward nephrogenic DI. Next, what factors or substances cause hyperkalemia? So we talked about things that shift potassium out of cells. Acidosis, insulin deficiency, beta-adrenergic antagonists, digoxin, and cellular lysis. But I also want to throw in potassium-sparing diuretics and ACE inhibitors. Now, those don't cause potassium to shift out of the cells, but they can cause hyperkalemia. And then the next question, what factors or substances cause hypokalemia? Again, the things that shift potassium into cells are insulin, beta agonists, alkalosis, and potentially cell proliferation. Then we can add loop diuretics and thiazides as potential causes of hypokalemia because they cause the patient to dump a lot of potassium into the urine. So that's it for the end of session quiz. And now we have 3 rapid-fire facts. So the treatment for central DI, again, it's desmopressin. The treatment for nephrogenic DI is hydrochlorothiazide or HCTZ, indomethacin, and possibly amiloride. And the treatment for lithium-induced nephrogenic DI is amiloride. All right, see you next time.
What are the causes of hyponatremia? Just remember the 60s, the 60s. Diuretics dehydration, diabetes insipidus, docs, diarrhea, and disease of the kidney. And that sounds funky. Oh yeah, the 60s, the 60s, hypernatremia, hypernatremia.